Hello, everyone. I am Dr. VC Manoj, and on behalf of Team NNF India and Learn from the Legends, thank you all let me welcome you and thank you all for joining us today. Hearty welcome to this 77th session in this 4th year of Learn from the Legends International Neonatology Webinar Series. We have today a very interesting discussion on one of the most common problem that we all encounter in our day-to-day practice, sepsis. If you remember, this is the third session on sepsis that we are having in our webinar series. Well, what's new in sepsis? We have a doyen in this field, a true researcher and legend to update us about sepsis and its biomarkers today. Professor Joseph B. CANTEY from University of Texas, USA. Hearty welcome, Professor CANTEY. It's a true honor to host you. We have two senior consultant neonatologists, Dr. Prakash Manikot from Muscat, Sultanate of Oman, and Dr. Subhash Chandra Shaw from Army Hospital, New Delhi, India, to moderate today's session. Without wasting any more time, let me hand over the floor to the moderators. Over to you, Dr. Prakash and Dr. Subhash.
Thank you for that handover. First of all, let me offer the greetings from Muscat, called the Jewel of the Gulf. Let me extend a warm welcome to the legend of the day, Professor Joseph B. CANTEY, my co-moderator, Dr. Subhash Chandra, and the worldwide participants. I thank Dr. VC Manoj, the chairman of the Learn from the Legends team, for giving me the privilege to moderate today's session. Neonatal sepsis globally and in low and middle income countries particularly presents with great challenges in identification and management due to the complexity of the disease and lack of a clear case definition. And this is coupled with its high incidence and lack of proper diagnostic facilities, especially in LMICs. These factors ultimately make sepsis the major cause of neonatal morbidity and mortality worldwide. The current diagnostic testing in sepsis based on conventional cultures are often time-consuming and delay many critical decisions. Non-culture based techniques like biomarkers, nucleic acid amplification, and genomic sequencing offer promise to overcome some of the inherent limitations of the culture-based techniques. We are eager to learn from Professor CANTEY about all these things. And he is a person who has done pioneering work, authored about more than 70 publications in peer-reviewed journals, which received about 1,800 citations. Over to my co-moderator, Dr. Subhash, for a formal introduction of the legend, and thank you.
Thank you, sir. Let me introduce Professor Joseph Benjamin CANTEY. He needs no introduction, actually. He is an associate professor of pediatrics. He completed his undergraduate studies from University of Virginia and his MD from Medical University of South Carolina in Charleston, SC. He then completed his pediatric residency at Johns Hopkins Hospital in Baltimore. And then he completed 2 fellowships at the University of Texas Southwestern Medical Center in Dallas, and became the first formally dual-boarded pediatrician in pediatric infectious diseases and neonatal perinatal medicine. Now, he is heavily involved in clinical research and has published more than 70 articles in peer-reviewed journals. He has authored 3 textbooks on neonatal infections, and also he serves on the editorial board of the American Academy of Pediatrics Nelson's Pediatric Antimicrobial Therapy, as well as chapter author of the Red Book. Dr. CANTEY's particular area of interest include antimicrobial stewardship and responsible prescribing in the NICU and newborn nursery setting. He published the first prospective antimicrobial stewardship study in the NICU and has become a leading expert on nursery stewardship. He's focused on both improving the delivery of antimicrobial stewardship to infants born in low-resource settings, as well as expanding our knowledge of the adverse impact antibiotics have on the normal development of term and preterm infants. His other areas of interest include infection control, prevention in the nursery, as well as the pathogenesis, diagnosis, treatment, and longitudinal follow-up of congenital and perinatal infections, particularly herpes simplex, cytomegalovirus, and syphilis. So without wasting more time, let me welcome Professor Joseph Benjamin CANTEY. Over to you, sir. Thank you.
Thank you, Dr. Chandra. Thank you, Dr. Manikoff and Manoj. Thank you guys so much for having me. That was way more introduction than I deserve. And it's a very, I will go anywhere if anyone's going to call me a legend. That's very flattering. Very excited to be here today, and hopefully we'll have a good discussion. I'll do my best to keep an eye on the chat box for questions, and we'll definitely have a lot of time at the end for me to answer my questions, answer y'all's questions to the best of my ability. So that being said, let me see if I can do this successfully after all the practice. Are you guys seeing my screen?
Yes.
Are you guys seeing the? Perfect. Okay. So thank you so much for having me again. Today, we're going to talk about biomarkers for the diagnosis of neonatal sepsis. And we're going to talk a little bit about where we've come from. We're going to talk about where we are today in sort of the global neonatal intensive care field, and where might we be headed in the decades to come. I have no disclosures. Okay, so we're going to define neonatal sepsis, which is obviously very much easier said than done. We're going to talk about biomarkers. We're going to talk about the theory of biomarkers, what we're shooting for, and we're going to talk about the current reality of what is available to us. What are the current non-culture-based methods that we can use to help us or not diagnose neonatal sepsis? And I'd like to spend a little bit of time at the end talking about where are we going? What's right over the horizon? What's coming that might be a tool to help us in the years or decades to come? So defining neonatal sepsis, easier said than done. So originally the word sepsis comes from the Greek sepo, which means to rot. It's a very graphic, vivid description of sepsis, and it's probably something most of the people, if not everybody on this call, has experienced, watching a baby get septic and disintegrate right in front of us. That definition has evolved from Aristotelian times all the way through to today. The consensus definition that is most widely used in adult medicine right now comes from 2016. It comes from the International Consensus Definitions for Sepsis and Septic Shock, which most people just refer to as Sepsis 3. Sepsis 4 meeting has happened. The publications are starting to trickle out, so these definitions are about to get updated again for adults. But it's important to note that this sort of standardized definition of sepsis does not exist for neonates. There's no current consensus definition for neonatal sepsis. And that's a problem for a couple of reasons. One of which is I and everybody on this call, we throw around the term sepsis colloquially, but what's sepsis to me might not be sepsis to Dr. Chandra, which might not be sepsis to Dr. Varanatu. So how can we come together on an official, not only a research definition, but also a clinical definition of neonatal sepsis? Lots of people who are smarter than me have written on this. If this is a topic that's interesting to you, I highly recommend anything that Jim Wynn, W-Y-N-N, has written. He's a doc from Florida who's written a great deal about the definition of sepsis. But this is something that we probably need to tackle at some point. But it's hard because, like everything else in neonatology, newborns have such non-specific, heterogeneous ways to show us their clinical signs that it's really hard to kind of squeeze everybody into one box. So for the purposes of this talk, what I'm talking about when we say neonatal sepsis is organ dysfunction in the setting of infection, right? So you have to have both those things together. If you have a urinary tract infection that's captured completely incidentally, I'm not going to call that sepsis because there's no organ dysfunction. Same on the flip side, if you have surfactant deficiency or you have hypotension because you're a 23 or a 24 weeker, or you have cholestasis because you have biliary atresia, but you don't have an infection, I'm not going to call that sepsis. That's organ dysfunction due to other causes. So organ dysfunction in the setting of infection, and generally that infection needs to be of a sterile site. So blood, urine, spinal fluid, in rare cases, things like peritoneal fluid or pericardial fluid, or even vitreous humor. But if it's a non-sterile site, if it's skin, if it's the endotracheal tube, if it's a JP drain that's coming out of the belly, and you have an infection of that site and you have significant organ dysfunction, we're probably still going to call that sepsis, even though those sites aren't specifically sterile sites. Ancillary biomarkers, so non-culture-based tests, complete blood counts, C-reactive protein, a million others, are often used to guide the diagnosis of sepsis, despite the fact that their utility is not always as good as we think there is. We're going to walk through some of this in the talk today. But I really want to highlight that the reference standard for this field remains a well-drawn blood culture. So this was work from Bob Shalanka, formerly of Texas. He now practices out in Oregon on the west coast of the US. And he demonstrated 30 years ago that blood cultures are extremely sensitive to even low levels of bacteremia. And we know from quantitative studies that neonates with early onset sepsis, their average amount of bacteria in their bloodstream, so the average amount of colony forming units per milliliter of blood, is somewhere in the range of 50 to 100. And you can see this table over here from Shalanka's work. The number of the concentration is that first column, the number of CFUs per milliliter, and the volume of the sample drawn are those columns going across. And you can see that even down to as low of a concentration as 5 CFU per ml, if you get 1 milliliter of blood into that blood culture bottle, your sensitivity is in excess of 99%. My trainees, and I think a lot of the neonatologists and certainly a lot of the trainee neonatologists in the United States have this perception that cultures are not particularly sensitive, and that's not true. A well-done blood culture, so drawn correctly and drawn with sufficient volume, is actually a really, really good test. And the whole keystone of sepsis has got to be that we're getting timely cultures, and then we're trusting them as much as possible. If you are interested in low CFU, like what if it's only 1 or 2 per ml? What does that mean? Or what if I don't have a good culture? If you're interested in the topic of culture negative sepsis, that's another passion project of mine. I've written some stuff on that. I highly recommend the recent one that we did with a doctor named Pavel Prusakov that was published in Journal of Pediatrics. I think it's a really good sort of breakdown of this, but it's too long of a topic to get into today. So I'm just going to shamelessly plug that other article and push on. But a well-drawn blood culture remains the reference standard. The other thing we have to remember for sepsis is that sepsis is relatively rare. We were talking before the meeting that the incidence of early onset sepsis is, in my institution, is about 0.5 per 1,000 live births. I have a relatively low resource indigent population that may not have had great prenatal care. In Oman, 0.1 per 1,000 live births. In Kigali, where one of my former fellows is now practicing in Rwanda, their rate is about 3 per 1,000 live births. So it's very heterogeneous. But even the most common places, sepsis is relatively rare compared to other things. So apnea, respiratory distress, hypotension in preterm infants are all 10 to 100 times more common than sepsis. So your average 24-weeker with hypotension and respiratory distress is actually not septic because surfactant deficiency, RDS, BPD, hypotension, hypothermia are all extremely common in the setting of prematurity, much more common than sepsis itself is. For term babies, it's almost worse because term babies, respiratory distress syndrome, TTN, atelectasis, all very, very, very common in your low-risk full-term baby that probably does not have sepsis. So we have to remember when we're looking at these babies that the pretest probability of them having sepsis is not as high as we think it is. So what that translates to for clinical practice is we work up a lot of babies that don't have sepsis. So this was a study done by the California Perinatal Collaborative led by Dr. Schulman. They looked at over 300,000 live births in California at 121 different centers that were participating in this collaborative. And what they found was the median number of sepsis workups and empiric antibiotic courses that they needed to perform for every case of early onset sepsis that they diagnosed was about 95. For late onset sepsis, that number gets better, but it's still 20. We still work up about 20 late onset babies for every baby that actually has infection. The reason the number drops, as you guys on the call know, the reason that number drops is we know those kids better, right? On day of life 1, if a baby has a couple of apneas, a bradycardia, gets cold, and gets hypoglycemic, I'm probably going to work them up. And I'm a huge steward, but I'm going to work that baby up. But 4 weeks later, when his name is Javier and he's sitting over there in the isolette in the room he's been in for a month, and I know that he has 2 or 3 bradycardia apnea events every day, and we just took him out of the isolette and into an open crib, and he gets cold, and we put him back in the isolette, and he has a little bit of hypoglycemia because the nurse missed a feed, well, I'm going to blow all those symptoms off, even though they're the exact same symptoms that the baby had for the early onset workup. So the only difference between early onset and late onset is that we know the kids better. We have an established baseline, so we don't work them up as often for late onset sepsis. But a number needed to test of 20 is still really, really high. If we did 20 bone marrow aspirates for every case of leukemia we diagnosed, we'd probably have to look at our processes if we were hemonc docs. So 95 and 20 are very, very high numbers in terms of number needed to test for sepsis. This leads to another shameless plug. I promise this is the last one. What I call the Spartacus problem. And if you haven't, I highly recommend this movie. It's from the 60s. It's great. But the point is that we have a really hard time distinguishing infected babies from uninfected babies clinically. We're all on this call. We're all seeking continuous medical education. You guys are all good frontline providers, and I promise you, like me, you guys probably struggle to tell which baby has infection and which baby doesn't when they're having all of these heterogeneous symptoms. And what that translates to is, most of the time, we will work these babies up liberally, okay, 95. And so that this treat them all and let the culture sort them out approach is very pervasive where I practice and across most of the globe. The reason I call it the Spartacus problem, if you've ever seen the movie, is Spartacus is an escaped slave and the Roman army's looking for him, and they finally catch up to the slave army, and the Romans have no idea what Spartacus looks like. And so rather than run the risk of missing Spartacus, they just execute everybody in the whole army. And that's how we treat early onset sepsis. We're trying to figure out which baby's the needle in the haystack. We just treat them all and let the cultures sort them out. Okay, biomarkers. Biomarkers, in theory, are amazing. Wouldn't it be wonderful? Wouldn't it be fantastic if we had this really fast, accurate test that would preclude us having to treat these kids? If we could do a blood test and know in advance whether or not the baby needed antibiotics, that would be such a home run, or such a six, to use cricket term. That would be such a wonderful victory for antimicrobial stewardship. And what we would need to have that was highlighted by Jorn Heinrich Weitkamp in this article from Clinical Infectious Diseases a few years ago. And what he said is, what we need is a sensitive enough test where the negative predictive value of that test is approaching 100%. So if that test comes back negative, you are confident the baby does not have sepsis and you don't have to start therapy. You also need a pretty specific test because you want a positive predictive value that's pretty good. It doesn't have to be perfect like the negative predictive value does, but we want a pretty good positive predictive value. We want a test that identifies the condition before the kid is overtly septic. Like once the kid has lots and lots of clinical signs and looks terrible, I don't need a biomarker anymore. That kid is going to get treated. So we need something that is an early warning system. We need favorable kinetics. We need a test that goes up before infection and then comes down with treatment, so we know when to stop treatment. We need well-defined cutoff levels for what all those are. And it needs to be low blood volume, and it needs to be fast turnaround time. If we send it out and it takes 5 days to come back from the lab, that's not going to help us. We have to make a decision in real time. And then lastly, it would be very nice if it was cheap, okay, so that it could be generalizable to medium and low resource settings. Weitkamp correctly says that test doesn't exist. There is no test for neonatal sepsis that meets all of those criteria that he's asking for. But that is the holy grail. That's what we're shooting for. And we're going to talk a little bit about some candidates for this particular slide later in the talk. Okay, what we actually have is biomarkers right now that don't perform as well as we wish they did. Okay, the sensitivity of most of these tests is mediocre. So if you have a baby with sepsis and that biomarker comes back normal, We've missed that case of sepsis, and that's what happens now. Sensitivities are 65, 70, 75%, which is okay, but we need it to be close to 100% because we can't afford to miss a case and not start antibiotics on that kid. The negative predictive value for most of these tests is still good because sepsis is really rare, but so is a coin flip, right? If something is really, really rare, the negative predictive value of anything, including guessing, winds up being good. So the negative predictive value being 92% isn't as good as it looks like. The sensitivity needs to be close to 100%. Specificity is pretty poor, and because the specificity is poor, you get some false positives, and when you don't have that many true positives, your positive predictive value goes down. And so the positive predictive value of every biomarker we have right now stinks. The third one is it wastes blood, and this is a big deal. Hands up, mentally hands up, if you've ever taken care of a 600-gram baby or a 700-gram baby, that baby's only got about 50 milliliters of blood in their body. And for that initial round of labs, you've got to get your blood gas, you've got to get a glucose, you've got to get a blood culture, you've got to get type and screen, you've got to get chemistries, all this stuff you have to get. And if you're also drawing a half a milliliter or a milliliter for an IL-6 or a CRP or a procalcitonin, that's more blood you're taking out of the baby. I'd rather we put that blood into the blood culture because the blood culture is the reference standard until we have a test that's good enough to be worth spending the blood on. And finally, most of them are not fast enough to be helpful, which we'll talk about. So here's what we've got right now. And you can't talk about biomarkers without talking about the original biomarker, which is complete blood count. So this is a study from 1966. This is on adult patients, but I love going as far back in human history as we can as an ID doc. So this is a description of toxic vacuolization of the neutrophil. And I pulled the text out down below, but they said, we've been particularly impressed that these changes are correlated with sepsis and they lead to the diagnosis of sepsis prior to bacteriologic confirmation. So there's that. We need a test that tells us the patient has sepsis before they look really, really, really sick, prior to bacteriologic confirmation. The problem is CBCs don't perform that well in neonates, and there's a million of these studies. This is one of the larger ones, so I pulled this out as an example, but if you meta-analyze a lot of CBC studies, you'll get a similar answer to this. This was done by Mikhail, who's now out in California. He published it 10 years ago, which makes me feel old. And you can see he had over 2,000 babies, only 9 of whom had early onset sepsis. So this was about 4.5 cases of early onset sepsis per 1,000 live births. So this is a very high incidence of early onset sepsis. This was a high risk preterm population. And in this case, the sensitivity and specificity of the CBC is hovering right around 70%. The positive predictive value is 1%. I'm going to say it again. The positive predictive value is 1%. So 99% of the babies who had abnormal CBCs did not have sepsis. Okay? The negative predictive value was quite good. It was 99.7%. And the reason for that is only 9 babies out of 2,000 had sepsis. So everything's going to have good negative predictive value. But 70% sensitivity and specificity is not good enough. This is a larger study looking at CBCs. This is from Mednex, which is the large multi-franchise private group that employs a lot of the US neonatologists, about 70%. They take care of hundreds of thousands of babies every year. And they looked at 166,000 infants who had CBCs sent for early onset sepsis evaluations. And they looked at every different way you can carve a white blood cell count up: total white blood cell count, immature to total ratio, immature absolute count. And what they found was the best marker out of all of those was the I to T ratio, the immature total whites to the total white blood cell ratio. And that best marker, the sensitivity was only 55%. And most of the infants with sepsis had normal CBCs. So their conclusion, which I totally agree with, is that obtaining a CBC solely for the purpose of ruling out sepsis was not supported. And that's true. Now, we often get CBCs as part of early onset or late onset workups because we're interested in the hemoglobin or the hematocrit. We're interested in the platelet count. So there's other good reasons to get CBCs, but we should not be reliant on the white count and the white count indices to rule in or rule out sepsis. It's just not a good enough tool. All right, C-reactive protein then had its time in the sun. So this is a meta-analysis from Dr. Brown in London. looking at 22 studies and over 2,000 infants looking at C-reactive protein for late onset sepsis. And what she found was that at the median specificity, the sensitivity was about 62%. And you can see that receiver operator curve on the right. What we're really looking for is a study that lands in that red box, kind of 80% sensitive, 80% specific plus. And as you can see, none of the 22 studies that were analyzed land anywhere near that box. The dashed line is a coin flip. The CRP performs a little bit better than a coin flip, but only a little bit better. And she said the determination of CRP level as part of the evaluation of an infant with suspected sepsis is unlikely to aid early diagnosis, right? So CRP is not it either. We turned our attention to procalcitonin, and this was a study that was pretty popular. You guys may have seen this one, the Neopen study, which was done in a couple of different countries. 1,700 babies who were either late preterm or full term. So these are bigger babies, and they got procalcitonin at 12, 24, and one more between 36 and 72 hours, or they just got blood culture by itself. And what they found was that of the 27 infants out of those 1,700 that actually had early onset sepsis, the area under the curve of procalcitonin at 12 and 24 hours was worthless. But at 36 hours, the area under the curve was pretty good. It was up there in that red box, it was 0.92. However, that takes 36 hours. And by 36 hours, the culture's back. So you've got your reference standard back by the time the procalcitonin is useful. The other problem with this study is they were using the procalcitonin to limit antibiotics, and they did show reduction of antibiotic duration in the procalcitonin group, but the average duration, even in that group, was 55 hours because they were waiting on the third test. We stop our antibiotics in my unit for early onset sepsis at 24 hours. Most places do between 24, 36 to 48. So 55 hours is already too much therapy. So by the time the procalcitonin is useful, you've already gone over where we should probably be targeting. IL-6, a couple of studies on IL-6. There's another big one coming out from Roche in about a month that's going to show the same thing. Again, sensitivity, mid-70s, specificity, 81. And that looks pretty good in that King study, but those were highly curated controls. Those babies had to have normal CBCs in addition to sterile cultures. So if you take all comers with sterile cultures, the sensitivity and specificity probably drop a little bit, closer to what Eichberger found, where the sensitivity and specificity for early onset sepsis was in the mid-70s. So again, not terrible, but we really need things that are pushing up at least into the 80s and preferably into the 90s if they're really going to be clinically useful to us. There's a million others, and to be respectful of time, I didn't dig deep into all these because I want to get to the fun stuff, but presepsin, CD64, which is a immunoglobulin binding site on macrophages, that got a lot of attention for a few years. Amyloid A, LPS binding protein, and so on and so on and so on and so on. And we're going to get to some of these later in the talk, but right now, CBC, CRP, procalcitonin, IL-6 are the 4 best studied, and none of them are useful enough to be a tool that we rely on. But what's coming? There is some very cool stuff coming. Okay, so and a lot of these are not blood-based. So one of the ones that's probably the most widely used, if not widely accepted, is heart rate characteristics. So it's been shown that if you track heart rate variability, heart rate accelerations, heart rate decelerations, resting heart rate, very similar to how we would do fetal monitoring before these babies are born, that you can sometimes anticipate clinical changes. So this was an initial study that was sort of a proof of concept study that came out of the UVA and Wake Forest system. I'm biased. I went to University of Virginia for undergraduate, and UVA has long been a champion of non-invasive heart rate monitoring. But this is what it looks like in clinical practice. So this was a clinical trial in preterm babies where they looked at regular clinical care versus clinical care plus heart rate characteristic monitoring. And that top number up there, that red number, is a multiple. So 1.0 means the baby is at baseline. As that HRC trend gets higher, the number goes to orange and then ultimately to red as the risk for sepsis gets higher. And the things that drive that up is lack of variability, lack of accelerations, tachycardia, bradycardia, change in resting heart rate characteristics. And what they found in this pilot study was that HRC monitoring could reduce the mortality rate. It made them draw culture sooner. It made them identify sepsis maybe a little bit sooner. It has not been borne out as well as they would like in larger centers. So How much of that is that it's not as good a tool as we think? How much of that is lack of familiarity with the tool? We don't know yet, but there's a lot of interest in scaling up HRC monitoring to see if it can help diagnose sepsis in these very low or extremely low birth weight babies. This is a study in the Netherlands where this is probably the most promising study outside the US for heart rate variability monitoring. So this was in the Netherlands. They did 4-year time series analysis. So they did about 1.5 years of standard of care. Then they phased in heart rate monitoring over a year. And then they did another 1.5 years where everyone was getting heart rate monitoring. And what they found was that they definitely decreased antibiotic use. They reduced antibiotic use by about 10 days of therapy per 1,000 patient days, which is not nothing. It's a mild but statistically significant reduction. They also had a trend towards decreased mortality. Now, it did not reach statistical significance, so take that with a large chunk of salt. But they did feel like they were getting a better handle on babies getting sick before they clinically became sick. So this is probably the most promising study. This came out 2 years ago in the European Journal of Pediatrics. Microbiome monitoring. This is something that Joseph New has driven all over the world. He's at the University of Florida. This study is actually one of Joseph New's studies. Dr. Mai was one of his fellows back in the day. And she did a case control study of 9 infants with necrotizing enterocolitis and 9 controls. And what they found when they compared those two fecal microbiomes between those two groups is that there's a proteobacteria surge in the days before the infants with NEC developed the NEC. And that surge was not seen in controls. What that means, proteobacteria is a family of bacteria. It includes E. coli, it includes Klebsiella, it includes Enterobacter, it includes all those nasty gram-negatives that we tend to see pop up in our blood cultures and our urine cultures. And what they saw was that a couple of days before the baby became symptomatic with NEC, E. coli, Klebsiella would surge and become the dominant, most concentrated, most abundant bacteria in these kids' guts, almost like an early warning sign that something bad was about to happen. This was the initial study, and they've now taken that surge and applied it to prospective observation of these studies. So this was Orkanian and Advances in Biology 2022, not a journal that I read routinely. I'm not going to pretend like it is. But they did 85 preterm infants, and every day they would swab their mouth, their skin, and their stool and build this daily fingerprint microbiome, which has got to be expensive, but it's getting cheaper every day. So they would build this daily fingerprint, and what they found was that antibiotic exposure, breast milk feeding, and age would change those fingerprints and change those fingerprints for the worse in the case of antibiotic exposure. They could then use those fingerprints to with machine learning to do what's called a growing bag analysis, where the computer will take the data every single day and look for trends, look for changes. And what they found was that fingerprint could be used to detect that proteobacteria surge and warn clinicians, hey, this kid's about to get NEC, or this kid's about to get late onset sepsis because look what's happening to their microbiome. So this dynamic risk score can be calculated every day based on these 3 swabs. Those 3 swabs are getting cheaper and more widely available as the years go by. That fingerprint, that daily fingerprint in this particular study had a sensitivity of 86% and a specificity of 90% for subsequent NEC or sepsis. So now we're talking, now we're up into the 80s, early 90s. So this microbiome sampling, if it can be widely applied, might be something that can help us. What I think would be even easier is transcutaneous monitoring, right? We've all used pulse oximetry, and there's been studies looking at changes in pulse oximetry as a risk factor for illness, for sepsis and NEC. Not just the oxygen saturation, but also perfusion. How strong is the signal? How much capillary flow are we getting where that transcutaneous monitor is? And increasingly, not just oxygen transcutaneous monitoring, but carbon dioxide transcutaneous monitoring is becoming more widely available as they're getting better at refining the probe. I would love to stop using in-tidal CO2. We've all had our struggles with in-tidal. Wouldn't it be nice if we could have a pulse ox that had the oxygen and the carbon dioxide up there on the monitor for us? So extending that technology to other molecules is certainly getting to be within reach. So this is a study in International Journal of Biology and Macromolecules, another journal I do not read routinely, But this was a proof of concept study where they looked at, could they engineer a probe that would detect serum amyloid A? Now, serum amyloid A is one of those biomarkers that people have been interested in looking for sepsis. And what they know is they can create an electrode that will detect serum amyloid A directly from blood. What they're now working on is, can they apply that transcutaneously? Can we look through the skin into the capillaries and look for circulating serum amyloid A? Or down the road, circulating lipopolysaccharide from gram negatives, circulating peptidoglycan from gram positives, circulating 1,3-beta-D-glucan for Candida. Like, could we have transcutaneous monitoring for all of these different pathogens? And what a treat that would be. So curving this back around to Dr. Weidkamp's study, what are we looking for? We're looking for something that has all of these features, okay? Something that has a high, almost perfect negative predictive value, something that's low or no blood volume, something that's fast, something that's easy to interpret, and maybe something that's non-invasive, something that doesn't require blood at all. So I propose to you that down the road, we might have something like this, and you tell me if this sounds good to you or not. So on admission, you've got your preterm baby. You're going to place the SeptaCheck probe on the infant's right hand. So you're going to have a pulse ox on this finger, and you're going to have the SeptaCheck probe on this finger. SeptaCheck is a continuous, non-invasive monitor that senses a combination of heart rate, tissue oxygenation, and circulating bacterial metabolic products. It is 99.3% sensitive and 94% specific for sepsis. If the SeptaCheck turns yellow up on your monitor, you get blood cultures plus minus urine and spinal fluid cultures. If the SeptaCheck turns red, you're going to go ahead and get those cultures and start empiric antibiotic therapy. We don't have that yet, but we're not that far away. So how do we get, how do we get from where we are to that sort of Garden of Eden situation? So what we can do right now, and I beg you, most people ignore me, that's fine. I'm contractually obligated to say it. Please stop relying too much on white blood cell counts, CRPs, procalcitonin. If you're going to draw that blood, put that blood into the culture. The culture is your reference standard. If you are going to use biomarkers, please rely on them for their negative predictive value. Okay, if the baby has a normal CRP and a sterile blood culture, or a normal white blood cell count and a sterile blood culture, you can feel really good about stopping your antibiotics at 36 hours or 48 hours or whatever the practice is. What I don't want is anyone to have a baby, draw a culture, draw a CRP, have a well-appearing baby, a sterile culture, and a white blood cell count that's super elevated, or a procalcitonin that's super elevated. And you're like, you know what? I'm going to treat this kid for a week just to be safe. Don't do that. The positive predictive value is really, really, really poor. Trust your cultures. If you've got bacteria on your cultures, that's a whole different story. But if your cultures are sterile, trust them, okay? And again, 24 hours, 36 hours for early onset, maybe up to 48 hours for late onset. We don't need to be going 3, 5, 7, 10 days for these sepsis rule outs. Okay. Tomorrow, going forward, we need to keep looking for biomarkers that will help. I don't want the take-home message. I know I come off like this because my residents tell me this all the time. I'm not trying to poop all over the biomarkers. We need a good biomarker. We just don't have one right now. But we need to keep looking for biomarkers that will help, ones that are going to have sensitivity and specificity that are clinically useful. And we need those biomarkers to be able to identify babies before they are sick. So we need to do translational studies, we need animal studies, we need observational human studies. Finding out the baby's sick at 48 hours when the culture is already positive does us no good. We have to do it in advance. And to do that, we've got to partner with engineers. I'm a liberal arts major. I was a psychology major with a minor in English. I'm useless. They don't let me in the lab. I can't build anything. I can barely work with Lego. So we need to partner with engineers, biomedical engineers, computer scientists, electrical engineers, chemical engineers, right? We need help from people who know how to build these complex systems. Some of you on the call probably are those people, in which case, please help us, because this poor liberal arts major can't do anything that's actually productive. Ultimately, what we want to do is have a test that's good enough to help us not start antibiotics in the first place. That would be amazing. But to safely withhold antibiotics, we need a test that's fast and we need a test that's accurate, because if it's not fast or not accurate, we're going to have to start therapy anyway while we wait on cultures. Okay, thank you guys so much. I know that was fast. I wanted to finish and make sure we had enough time to do questions and have a discussion. But again, thank you guys so much for having me. It was an incredible honor. Thank you to the moderators and the organizers, and I'm happy to answer any questions I can.
Thank you so much.
Thank you very much. Sorry, Manoj, carry on.
Yeah. Thank you so much, Professor CANTEY, for that very interesting talk with a lot of thought-provoking ideas. So I'm sure there will be a lot of questions. But before we go on to the discussion, with your permission, we will just play one 1 minute video on the promotion of the upcoming National Conference of Neonatology Forum.
Hello. You hardly questions, eh? No, nothing. Can you see? Yeah. No. Yeah. No. I have made already 3 or 4, and not. Yeah. There are only not a single question. The first time in my last 3 years, and participants also very few. I don't know. Maybe other things. Yeah.
Thank you.
That looked beautiful.
Thank you. We would invite you for the conference if you have the time.
My kids are in high school. As soon as my kids are in college, I'm flying anywhere you guys want me. That looked amazing.
Next time,
and Dr. New and Dr. Satyan is a legend. So that's going to be really a great panel.
We have some true legends, maybe all the names are not there. There are more, like Professor Neena Modi and all, whose names are not there in that list anyway. So, without wasting any more time, let's go on to the discussion. May I request the moderators to kindly take over again.
Yeah, before I start the questions, thank you very much, Professor Joseph CANTEY, for an amazing and extensive presentation updating us about the role of biomarkers in neonatal sepsis. I'll take the first few questions. Dr. Ram Kumar has asked, what is the current recommendation you can suggest, and what will be the top reasons to do procalcitonin in neonates?
So I think there are 2 circumstances where our current repertoire of non-culture based biomarkers are useful. One of which is if we don't have a culture. So if you have a baby where the child was born and looked incredibly sick and there was access issues and you don't have time to get a blood culture and you feel like clinically the best thing to do is to go ahead and start antibiotics, that happens. And maybe you inherit those babies from a transfer from another center in your region. In that case, serial biomarkers and seeing those be negative or normalized might help you feel comfortable stopping antibiotics sooner rather than later. So one is if you don't have a chance to get a good culture. The second one would be if there is no access to culture. So I have a couple of nurseries that I help in sub-Saharan Africa that don't have microbiology available to them. And in that case, you've got to rely on, if you don't have culture, non-culture based methods are all that's left to you. So in that case, serial biomarkers are the next best thing. Now they're significantly worse than culture, but they're better than nothing for sure. So that's my recommendation, is if you don't have a culture or for some reason somebody got in your way and you can't get a culture before antibiotics, non-culture based methods might help you.
Thank you for that clear explanation. The next one is from Dr. Rani Bashir. She has complimented you for a great talk. Her question is, what is the sensitivity of blood culture in neonatal sepsis? I'm sure you mentioned, but if you would like to.
Yeah, no, absolutely. It depends on how many organisms per milliliter are around. So, and it depends on how much volume you get. And the article that I highlighted is probably the best one because it actually has that table sort of built out. That's an in vitro study. He did that on a bench, so not in actual patients. But we know that quantitatively, the average septic appearing infant with a positive blood culture has about 50 to 100, sometimes as much as 500 to 1,000 organisms per drop of blood. And really all you need to do is capture one viable colony forming unit. If you can get one CFU into that blood culture bottle, there's no white blood cells, there's no complement, it's a perfect temperature, there's lots of growth media, and there's binding agents to suck up any antibiotics. So if you get at least one healthy CFU into that bottle will eventually grow. It's going to take, hours to days, but that bottle will grow. So it's really just the math then about how much blood and how much was there. But on average, if the baby has a meaningful number of bacteria or candida in their bloodstream, and you get at least 1 milliliter, the sensitivity is about 99+%. If you get a third of an ml or a quarter of ml because it's a really tiny baby and you're trying to ration your blood, your sensitivity will drop. So we want to make sure that we emphasize getting a minimum of 1 milliliter whenever we can.
Okay, thank you. Dr. Jagadish Sahu is asking, what is the role of serial CRP in a clinical picture of sepsis in a setup where you don't have adequate manpower for monitoring the baby? Can serial CRP replace monitoring of the baby?
Yeah, so if I'm understanding the question, so if the baby if you're not starting antibiotics, there's lots of evidence from multiple different centers that serial observation is as good or better than starting empiric antibiotics on every kid with risk factors. If you're not set up, if that baby's in couplet care and you don't have the nursing power or the community health worker power to keep an eye on that kid every 4 hours, there might be a role for serial CRPs. They haven't really been studied in that context, so it would be a great thing to study. If the question is, once the kid's already sick and you can't watch the kid CRP, then my answer is the same as the first one. It's not as good as culture, but it's certainly better than nothing.
I think what he meant was in his baby with a clinical picture of sepsis, you keep monitoring the serial CRP and how relevant it is.
Oh, I see. Yes, again, if you're going to treat that kid for culture negative sepsis for 10 days, I hope people don't. If serial CRPs helps you feel better about stopping sooner, if the CRP goes down to normal at day 3 and you feel comfortable stopping at day 5, well, 5 days is better than 10 days. So if you're going to use it like that, go for it. But know that a lot of babies with abnormal CRPs may not, or abnormal white blood cell counts may not have sepsis, and you may be tracking something that's related to prematurity itself, or the fact that mom had choreo even though the baby's not infected. So there's a lot of reasons for falsely elevated tests, but if you're going to use a normal or normalizing test to help you do stewardship, go for it by all means.
I think it's a common practice in low and middle income countries to rely on the CRP to start and to stop, if I'm not mistaken.
Yep. And again, if you don't have access to culture, you're doing the best you can with your resources. If you do have access to culture, I would put your faith in the culture.
Okay. Can I switch over to Dr. Subhash for the next set of questions?
Thank you, sir. There's a great question by Dr. Abhishek. He asks that there is always confusion in starting antibiotics for babies born with absent or reversed endosylate flow, as they have feed intolerance clinically, and they also have neutropenia and thrombocytopenia on CBC with elevated CRP also at times. So in those cases, how do you decide whether the baby is septic or not? So these are the babies who often get antibiotics. They may not be having sepsis, but how to take that call?
Yeah, this is really hard. And my group is very guilty of this too. I myself have done this. The two situations, this one, like you said, preeclampsia, absent or reversed end diastolic flow, and they come out and their white blood cell count is 2.3 with 400 neutrophils and their platelet count is 60. I think in that situation, it's really important to step back and think again about the risk factors for early onset sepsis. So a lot of the babies who are born with this specific scenario, they're born from maternal indications. There may not have been labor. Rupture of membranes might have been right at delivery. There's probably not chorioamnionitis. So these babies are at now they're probably preterm in this particular setting, but they're at relatively low risk for sepsis compared to a baby whose mom's been ruptured for 16 hours and she went choreo and now the baby's born and has this exact same CBC. So in the absence of a lot of risk factors for sepsis, you sort of have to train yourself to ignore the CBC as much as possible, or start that baby on draw culture, start that baby on therapy. But then at 36 hours, trust yourself to stop. And even though the CBC won't normalize for a week or two, it's okay to stop. Ampicillin and gentamicin are great drugs, but they are not platelet transfusions and they are not GM-CSF. They are not themselves going to raise the white blood cell count or the platelets back up. So the reverse version of this is a 25-weeker with a leukemoid reaction where they're born, their culture's sterile, they look great, and their white blood cell count is 70,000. It's really hard to stop antibiotics when the kid's white blood cell count is 50 or 60 or 70,000. But you can, and the white blood cell count will come back down to normal. And you just have to train yourself to ignore the CBC, and over time, you'll get comfortable with it. I actually tell my residents not to recheck it. I'm like, I don't want to see that thing again. The baby looks good. But yes, this is a very, very challenging situation. And I've had times where I've held off, and the night call person comes in and starts therapy, and I come back the next morning, I'm like, why would the baby looks fine? So it's a really challenging situation. Again, in that setting, if you send a CRP or an IL-6 or something and it's normal, that might provide you some reassurance, but it's a hard situation to avoid treating a neutropenic baby.
Another question by Dr. Ram Kumar. He firstly thanks you for the great talk. And then the question is that does post-blood transfusion also causes rise in CRP or procalcitonin, blood transfusion itself? Have you seen that?
For yes, sir. So the limited amount of data we have in the US suggests that yes, it does. And it's pretty variable. It probably depends on how old the blood is and that baby's particular own genetics and own immune system. But we do see small to large bumps in inflammatory markers after, especially platelet transfusions, but packed red cells as well. I don't think FFP or cryoprecipitate does it. If so, I haven't seen those studies, but certainly platelets and red blood cells can be transiently inflammatory, and you can see those go up. The other one that causes big spikes is vaccination. You give those babies their 2-month vaccines, the next week their CRP is going to be real high.
Another question by Dr. Purbasa Mishra. She writes that in case where IT ratio is not available and blood culture report takes time to, the report to come, do you have any data or any your views on micro ESR? So micro ESR is something which is easily doable in clinical settings of ours. So do you rely on that?
We don't use ESR or micro ESR as much here. I would imagine I don't have a lot of practical experience, so take this with a grain of salt, but generally ESR is slower to rise and slower to fall. So the delay in elevations and delay in response to therapy might make it challenging to use at the bedside. But again, it might be better than nothing. So if the alternative is treating the kid for 10 days, use what you've got. But I think ESR is relatively slow relative to CRP and procalcitonin, where they're quick up, quick down. So just caveat that you might be seeing whatever happened to the baby 3 or 4 days ago, as opposed to 3 or 4 hours ago.
Thank you. Then Dr. Senthil asks, what's your opinion on molecular diagnostic for PCR panels? These are like, in India also they are available. The PCR panels for like respiratory panel or neurology panel. So what is your take on that?
I think this I'm not supposed to say it's a great question, but this is a great question. This is near and dear to my heart. They're wonderful tools. I tell my coworkers they're like chainsaws. They're wonderful tools. You just have to know what you're doing with them. The advantage to the molecular tests is that they can detect dead organisms. So if you've got a baby who gets sick and the outside hospital starts ampicillin and gentamicin or oxacillin and gentamicin or vancomycin cephalosporin and sends them to you, and you're like, oh, they didn't get a culture. You can still do a lumbar puncture and maybe get an answer. You can still do a blood test and maybe get an answer. So they have utility in the setting of pre-treatment, inadvertent or intentional pre-treatment. That's also their disadvantage. So if you have a mother who goes choreo and mom receives antibiotics before delivery, and that baby's born and looks okay, right? Or maybe he looks sick at first and then he gets better over 2, 3, 4, 5 hours. What may have happened was mom has E. coli, choreo, baby had some transient E. coli. The maternal therapy killed the baby's E. coli before the baby was born. And now the baby's born and the cultures are sterile. They're true negatives because everything's dead. The baby needs no antibiotics. Everything's dead. But if you draw the molecular test, it's going to go bloop, E. coli, and you're going to wind up treating that kid for 14 days. So it's great. The molecular tests are great. They're super sensitive. The molecular tests are dangerous because they're super sensitive. So you just have to be judicious about how you're using them.
Before I hand over again to Dr. Prakash sir, one more question by Dr. Hadi Faki. The question is, what is your opinion in the neonatal sepsis calculator tool to calculate the risk of EONS, early onset sepsis?
I love it. We use it at my center. We've used it everywhere I've worked since it came out in 2016. And full disclosure, I was one of the 3 reviewers for that initial paper when Karen Popolo published it. And I was super excited when it was first coming out. It could be a whole separate talk, so I don't want to get too excited because I'll go off on a tangent and that'll consume the hour. But it is very, very sensitive. So we do not miss any babies with the calculator. That we miss a very, very minimal number of babies with the calculator that is comparable to the number of babies we used to miss with our older, more aggressive, treat all the choreo babies, treat all the inadequately treated GBS babies. So you're not missing anybody, but you are significantly reducing NICU transfer, blood cultures, antibiotics. And Dr. Manicoth and I were talking beforehand about, in my center, we have to separate all the babies. So if a baby needs antibiotics, they've got to say goodbye to mom and dad and come up to our NICU for 48 hours. So I'm a huge fan of the calculator. My biggest regret for well, 2 things about the calculator. One is we desperately need one that applies to preterm babies. When we have a preterm early onset sepsis calculator, that'll be another valuable tool. And Karen Popolo and company are working on trying to validate one. The caveat with the calculator is if you plug everything into the calculator and it says no cultures, serial observation, that means serial observation. You can't be like, oh, it's yellow, we can forget about this kid. They've still got to be watched. And as someone asked earlier in the talk, you may not be set up to do that. Like in my hospital, you're either in the NICU or you're in couplet care with mom and dad goes back to work and mom's unconscious because she's been up for 25 hours. No one's watching that baby. So we have to be very careful about making sure that the babies who are at low risk but not zero risk are getting serially observed, because they can, as everyone on this call knows, they can turn in a hurry. But in general, I'm a huge fan of the calculator. Sorry, didn't mean to bury the lead there. A big fan of the calculator.
Over to Dr. Prakash.
Thank you. I think Dr. Rani Bashir has also asked a similar question. I'm sure you explained clearly about the sepsis calculator. And over to the next question, that is Abhishek. Dr. Abhishek asks you, when does the CRP raise to clinically significant values in early onset sepsis? I mean, the time period.
Yeah, so based on in vitro studies and animal studies, it probably takes only an hour or 2. It's probably pretty quick. the C is actually an antigen for pneumococcus, but it's a protein that the liver makes that recognizes a wide variety of pathogens, bacteria, and fungal pathogens. And if you take dead E. coli or dead Candida and inject it into an animal, the liver will start to make CRP within the hour. So, give it another hour to rise up enough to be detectable as abnormal, but it's probably within half an hour, 2 hours. It's not half a day or a day. It's pretty quick.
If I can comment on the answer, like if you read the NICE guidelines UK, they recommend CRP in a baby with a risk factor, not so early in the first 6 hours, perhaps between 12 and 24 hours.
Yep.
What's your comment on that?
I think for two reasons. One, there is that delay of an hour or two for it to start being produced, and then it's got to be produced enough to be above the whatever the cutoff is for an abnormal test. Secondly, most babies with early onset sepsis risk factors are not sick. So let me back up. If a baby has early onset sepsis at delivery, that means that mom has had ascending infection, the bacteria have reached the amniotic fluid or the placenta or the umbilical cord, and the baby's breathing those organisms in. So they're sick at birth. And if you do CRPs in those kids from the cord even, they're high. They can be high. They're also not super sensitive, so they can be normal, but if you wait 6 hours, you're also capturing the group who are well appearing at birth, but have been colonized with group B strep or E. coli or whatever the pathogen is going to be in their mucous membranes and on their skin. And over the course of 2, 3, 4, 6, 12 hours, those organisms can invade into the bloodstream. And so if you delay the CRP a little bit, you're going to do a better job of picking up that second group. And I think that's why the UK and the Canadian guidelines say, if you're going to do it, don't do it right at delivery. If the baby's well appearing, wait 6 to 12 hours so you can capture that second group as well.
Thank you. Dr. Geetanjali is asking, is prolonged rupture of membranes in the mother for more than 18 hours an indication to start antibiotics?
Thank you, Dr. Geetanjali. I'll send you your money offline. I appreciate the setup. So prolonged rupture of membranes has always been thought to be a risk factor for early onset sepsis. It's part of the sepsis calculator. You type in, hours of rupture. And certainly on boards and on testing exam, it always shows up as a risk factor. So I have to be careful about how I talk about this with my residents, because then they'll fail boards and I'll be in trouble for it. But there is pretty good evidence. So I'm getting excited now. There's pretty good evidence that prolonged rupture of membranes is a risk factor for chorio, and chorio is a risk factor for early onset sepsis. If you divide NICU babies into no prolonged rupture and no chorio, and then a middle group of prolonged rupture without chorio, that middle group behaves more like the healthy group than they do like the chorio group. So if it's a well-appearing baby and it's just prolonged rupture of membranes, I would draw cultures and observe closely, but I wouldn't start. If it's prolonged rupture of membranes and chorio, I'm going to be more likely to start. Certainly if the baby has any symptoms in the setting of chorio, I'm going to start antibiotics, but just prolonged rupture by itself, probably not for me. And again, it's practice dependent, but there's not great evidence that prolonged rupture in the absence of chorio is a major driver of sepsis.
Can I clarify your answer? Like if you have a prolonged rupture of membranes in a well baby, do you always do a workup? Or you observe for 2 days?
No, not always. And I'm in the NICU, if they're coming to me because of prematurity and they've had prolonged rupture, we probably will get a blood culture. But there's lots of babies at my center, they're ruptured for 22 or 40, or even, getting above that's pretty rare. But if they're ruptured for 18, 20, 24, 30 hours, and they come out, they're full term, they're well appearing, they're on room air, and they're going to couplet care, we're probably not going to work that kid up.
Okay. A related question.
I'm sorry, I didn't mean to cut you off. But the Kaiser sepsis calculator will probably say serial observation on that kid. So we will make sure someone's putting eyes on that kid at routine intervals.
A related question from my side. Should we screen a well baby for early onset whose mother has a temperature of 38 degrees, elevated WBC count, CRP of 80, 2 days after cesarean section?
Ooh, so mom spikes the fever, but it's after delivery.
2 days after cesarean section with elevated
I
count
would,
and CRP 80.
yeah, I would probably, I mean, unless they had concerns around the time of delivery that she was developing choreo, but we see a lot of surgical site infections or urinary tract infections in moms after the fact that shouldn't impact the baby's care. So I would say no. If the baby's looking good and everything mom had was 2 days after delivery, I would just keep observing the baby.
Okay, thank you. Dr. Maddy Reddy is asking, is there any research on point of care devices for sepsis?
Ooh, so mostly I didn't present all of it. Most of what is coming is stuff that is similar to what's in the PowerPoint, where it's either proof of concept, like can we engineer this thing, or a couple of case series or in vitro trials with a human baby. But in terms of large prospective cohorts or randomized control trials using devices for sepsis, really the only one that has meaningful data right now is the heart rate monitoring. But that's definitely the area that we should be mining. And whatever the next best biomarker is going to come from that point of care question.
Dr. Abhishek's questions has been answered. I think most people are fascinated by CRPs. Then I'll go to Dr.
Yeah.
Celia. She says, when cultures come back in your center, would you consider monotherapy even for cephalosporins? Or do you proceed with combination in your standard operating procedures as long as the drug with the sensitivity is part of the combination?
We very rarely use combination. We're pretty much all monotherapy. And we, in the NICU setting, in the absence of meningitis, where we have to use the cephalosporin, or kidney disease, where we want to avoid the aminoglycosides, we tend to mostly do for, no, I shouldn't say that. That's, but we are very comfortable using monotherapy, and we use monotherapy with aminoglycosides. So if it's a E. coli bacteremia and the spinal fluid is clear, we'll probably use Gent for that if it's susceptible. For group B strep, penicillin or ampicillin. For urinary tract infections, we'll often go to, we'll usually be on monotherapy. Generally, the only times we're on 2-drug therapy is if it's a complex organism that's resistant to our initial stuff and we're waiting on micro to give us more info. So we might be on double empiric therapy, but once we know the susceptibilities, we'll try to narrow down to 1 drug if we can. Or for things, or for things like endocarditis or the first couple of days of GBS meningitis, where 2-drug therapy is recommended while we're trying to sterilize, like AMP and Gent for GBS meningitis until the spinal fluid's sterile. And then we would narrow down to just ampicillin. But 95% of our therapy is monotherapy.
Okay, thank you. Dr. Ismat Jahan has the following question. We frequently send serum lactate and blood gas to see metabolic acidosis to get supportive evidence for sepsis-related organ dysfunction. So her question is incidental findings of high lactate or metabolic acidosis in the blood gas predictive of sepsis and warrant antibiotic even in apparently healthy neonates?
So yes and no. Certainly perfusion as a sign of end-organ dysfunction is really important. And a lot of the transcutaneous monitoring is focusing on perfusion, oxygen delivery to tissue. So there's a right answer in there for sure. And monitoring lactate in a critically ill kid, I think is valuable. However, if the baby was otherwise well appearing, so if the capillary refill was normal, the heart rate was normal, the blood pressure was normal, I probably wouldn't be trending the metabolic acidosis in terms of sepsis, because we see so many other reasons for metabolic acidosis in our preemies, hypotension from prematurity, even just renal spillage. Most of our babies waste bicarb for the first 2, maybe 3 weeks. And so I wouldn't want to I wouldn't want to over-treat metabolic acidosis in an otherwise healthy kid. But if the kid was ill and a sepsis was suspected or proven, I think metabolic acidosis and lactates are good things to keep an eye on to make sure you're trending the right way.
My limited experience, quite often when the sample is collected in a bad way, the lactate is very high. And if you give
Very
proper
true. And
antibiotics,
that's true for, yeah, all of our point of care stuff. We have to be careful. And I'm spoiled rotten because we have great nurses, but I don't know what we do if I was the one drawing them, because I would always mess them up. They're finicky.
yeah, Dr. Madhi Reddy has asking, in centers with a high incidence of sepsis, do they need to develop a indigenous sepsis calculator? I think the first one is what is the incidence, local incidence, no? The first drop down menu, is it 1 or 10 per thousand? Or do they need to
Yeah, it
develop
is.
a
And
local
I'm gonna have to
sepsis
check real. I don't know how high it goes up. We're 0.5 at my center, so we're pretty spoiled because that's the default. So I never have to change it. Let me see how high up it goes. It goes up as high as 4 per thousand live births,
not more than
which
that.
is relatively high, but there probably are centers, especially if their population is high risk, that it's higher than that. But I think because they validated it only in the US initially, and our rate has historically ranged from 0.2 up to about 1 to 2. So even including 4 was a stretch for them, but there are centers that are higher than that.
So in a center where the pretest possibility, the local incidence of sepsis is 8 or 10 per thousand live births, can they multiply it or they have to make their own calculations? How do you
It's
apply the calculation?
exponential, yeah. So it's actually going to be higher than, so if your rate is 8 per thousand and you're stuck at 4 per thousand on the calculator, you can't just double it. It's actually even higher risk than doubling, because as the pretest probability goes up, those rates will go up exponentially.
Exponentially, yeah, quite right. Dr. Abhishek says preterm birth and meconium stain liker. Should we alarmed every time for sepsis?
I think it's very good to be alert for sepsis in those kids. I don't know that I would routinely start antibiotics on and there's actually data to support that we don't need to start antibiotics on every baby with meconium stain fluid or liquor. But something made that baby pass meconium, and if it's not clinically, if it's not, evident from abruption or evident from fetal asphyxia or something like that, one of the things that might have made that baby pass meconium is certainly sepsis. So depending on what the other risk factors were and how that baby looks, meconium is not a reassuring sign by any means, but I would not work up every single baby with meconium stain fluid.
Can I share my anecdotal experience? In the absence of meconium in the rectum, in a preterm, you should think about an intestinal obstruction also. Intestinal obstruction. Especially if you get a large volume at birth, you should have suspicion of a intestinal obstruction in the absence of meconium in the anal area. Otherwise,
Yes,
we think about listeria all the time.
Well, we actually had this last week where we had a 28-weeker and they said meconium stain fluid. I was like, and the baby wound up having ileal atresia.
Yeah, we have seen a couple of patients like that. So yeah, that's my take on that. Then Dr. Kedar is asking, what is the relationship between neonatal sepsis and maternal UTI?
Complex, but it definitely exists. One of which is maternal urinary tract infection, even if those bacteria get nowhere near the baby, can trigger preterm labor, preterm delivery, and then that baby is going to be at higher risk for sepsis because of the prematurity. But it also reflects maternal GI, GU carriage of that pathogen. And so that pathogen you're going to have to worry about. So if you've got a baby, if mom has a pan-susceptible E. coli UTI and the baby comes out at 28 weeks, well, that baby's probably going to get whatever your local empiric therapy for early onset sepsis is. But if mom has a UTI with meropenem resistant Enterobacter, you've got to take that into consideration when you're starting your empiric antibiotic. So we might start Cefiderocol. We might start some big gun on that baby, knowing that mom has this very scary resistance. So partly it's increased risk, and partly it's taking mom's flora into consideration when you're treating the baby empirically.
Thank you. Or Dr. Subhash for the next set of questions.
Yeah, thank you, sir. So one question is by Dr. Kedar that people use 2 different antibiotics in culture positive sepsis, sensitive to both. I think this question you've already answered, that you are very comfortable with even single drug, as long as it's not. It's
yes,
not
sir, that's
a
right. And there's really no evidence in neonates or even in older children to support 2 drug for bloodstream infections, for meningitis, uncomplicated meningitis, or for urinary tract infections, we should be fine with one. And the other thing is that a lot of these, depending on what drugs you're using, they might be competing with each other. So even AMP and GENT in vitro compete with each other, because if gentamicin is blocking peptidoglycan production at the ribosome, then there's no peptidoglycan for the ampicillin to hit. So you don't really get the benefit that you think you're getting. Now, if you've got an organism that's intermediate to two and you're like, oh, I need to hit this a couple of different ways, or if you've got an organism that's hiding in a really hard to penetrate spot like brain or bone, and maybe you want to use two drugs, fine. But generally monotherapy is going to be just fine for our babies.
What about MIC values? Do they help in some way in choosing the antibiotic?
I think in the setting of, if you've got a drug that's intermediate and you've got a drug that's susceptible that gets to your compartment that you're interested in, I would always use the susceptible one. But because the MICs are all specific to that agent, so if ampicillin sulbactam has an MIC of 4 and Zosyn has an MIC of 16, Zosyn might still be the better drug in that particular case, because you can't really compare directly to each other. But I certainly wouldn't use a drug that's intermediate or resistant if I had a better option.
What's your opinion about the minimum duration of antibiotic treatment in culture positive sepsis? How many days would you recommend?
So we have, I was looking to see if I had it behind me. We use the Red Book, which is the AP's guideline, and they're pretty conservative. So they would say, 10 days for group B strep, 14 days for a gram-negative, 21 days for meningitis. There's not a lot of empiric evidence to support that shorter durations are not safe. And there's some data to support 7 days. For pneumonia and urinary tract infections, 5 days, or even 3 days. Certainly there's some number that's too short. But I feel very comfortable doing 7 days for group B strep and doing 10 days to 10 days for gram negatives if the kid is doing okay. NEC is totally made up. There are exactly 0 randomized control trials looking at duration for NEC. Meningitis is fairly made up. So George McCracken, who taught me in Peds ID back in the day, and he was saying it to be funny, but it's a true story. He said, you treat them till they're better plus a day or two. So, if they look great on day 3, and I'd feel comfortable stopping at day 7. If I'm treating gram-negative meningitis and the kid looks horrible on day 18 and the MRI's got pus everywhere, we're going longer. We're not stopping at 21. So, but in general, I think 7 days, 10 days, 14 days, if you're hitting in that window, you're probably doing what most people would do. But we need more data. So anyone who wants to study it, go for it.
Can I ask a related question? Quite often we repeat a culture after starting antibiotics after 24 hours, right? So
Yes, sir.
your 7 days starts with the first negative culture. Am I right?
That's a good question. I think if they sterilize right away, you could just say 7 days of therapy. But for things like, Staph aureus, where sometimes they stay positive for 3 or 4 or 5 days, Candida, things like endocarditis, or if you've got an abscess somewhere you've got to drain, then you might not start the clock until the day that you sterilize or the day that you drain. But if they clear right away, it's kind of a moot point.
So do we need to take a repeat culture after starting antibiotics all the time, or it's not required?
I do think you want to know that they've sterilized. You want to know that your therapy is working. But once you've got, very rough rule of thumb, I usually get as many days of negatives as we had days of positives. So if a kid has a positive culture on Monday and Tuesday, I want a sterile one on Wednesday and Thursday, which won't be back until Saturday. So Saturday is when I'm like, okay, they're done. They're sterile now. But if it's one positive culture and then you get one negative culture, you're good.
Thank you.
What about these surface swab cultures like nose, genitalia, surface swabs? Do they have any role in today's world? Like, does it help?
So I'm old enough to remember these days. The problem is that the rate of colonization right after birth for things like group, especially if mom's not adequately prophylaxed, GBS is probably about 50%. About 50% of babies born to mothers with group B strep will have group B strep on them, but only 1% of them will get early onset sepsis. So if you do the surface swabs and they're negative, you great. But if you do the surface swabs and they grow group B strep, well, 98% of those kids are going to be fine. So you wind up over treating in the setting of using surface. So we don't, the only thing we really do surface samples for anymore is herpes at 24 to 48 hours. If we're worried about HSV infection, we'll look with molecular testing at 24 to 48 hours. But for bacteria, you're probably going to get a lot more information than you want, because these babies, especially if you don't bathe them initially, which we try not to let them establish their microbiome, you're going to get a lot of quote unquote pathogens that are just hanging out on their skin and are never going to invade into their body. So I would say no, I would say don't do it.
Excuse
Yes,
me,
sir.
can I ask, do you recommend weekly routine surveillance cultures for extreme preterm infants for early diagnosis and choosing the right antibiotic? Micropremise.
Right. So we do weekly swabs for MRSA only. We do that because our late onset sepsis therapy is oxacillin and gentamicin. We don't use vanc. We only use vanc for kids who are known to be MRSA colonized. I think we could probably safely get away with doing it every 2 weeks. I think every week is probably too much for the incidence in our unit, but somewhere between weekly, bi-weekly, or every 4 weeks seems to be the sweet spot, depending on your activity. And it helps us because because then if the baby's colonized with MRSA, they get vanc. If they're not, and methicillin susceptible Staph aureus is much more likely. Well, oxacillin or nafcillin or cefazolin are way better drugs than vancomycin for MSSA. So you optimize therapy for most of your kids and you save your vanc. So I like that. Other centers will swab for gram negatives. They'll swab for vancomycin resistant enterococcus. It just depends on your local epidemiology. If you've got an organism that you're dealing with and you want to know, go for it. But I don't know that we need to systematically swab every baby every week for all these bugs. It just depends on what you're seeing in your own unit.
Thank you.
Dr. Rohit Jadhav asks, for deep-seated infections like abscess, ventriculitis, etc. So any role of polytherapy, especially when you don't have any organism isolated in those
Yeah,
cases?
I think in this case, yes. If you don't know the organism, because in an older kid, if you've got a 4-year-old who comes in with a muscle abscess, well, that's almost certainly staph. So you could feel pretty good about staph monotherapy. But in our babies, it could be group B strep, it could be Staph aureus, it could be E. coli, it could be Candida, So we always have to worry about more bugs. So at least kind of 1 gram positive and 1 gram negative agent, you're probably stuck with if you don't know which bug it is. So yes, if it's a hard to get to place or if you don't know what bug it is, you might need to broaden therapy empirically. And that's a hard situation because some of our babies have these things you wish you could drain and you just can't get to safely.
Yeah, he also asks that what is the specific indication of repeat CSF as a routine for therapy response, like especially when meningitis was based on biochemical parameters done for late onset sepsis with no other neurological symptoms. So what is the role of repeat CSF in such cases?
Right. Rough rule of thumb is you always want to see at least 1 sterile spinal fluid. So for late onset sepsis. So if I've tapped a baby and they've got culture proven meningitis with E. coli or whatever, we're going to check them again towards the end of therapy to make sure that they've sterilized, plus minus get head imaging, ultrasound, or if it's available, MRI. Sometimes it's hard for us to get MRIs. But if you tap a kid and they're sterile, but they've got high white blood cell count or high protein in the spinal fluid and you treat them for meningitis, then I think it's a little bit debatable about, do you need to do another lumbar puncture when your first one was already sterile and you've done therapy? And I think it's just a cost benefit of how worried are you versus how's that baby going to tolerate lumbar puncture. But as long as you have at least 1 sterile, now if you've got a positive spinal fluid and never tap again, that's risky. But if you've got 1 sterile, you're probably okay not to tap again in most cases. And I love lumbar puncture. I'll tap anyone, but I don't know that I would re-tap a kid who's already sterile.
Okay. Then do you treat culture negative but sepsis screen positive cases, like in suspected CLABSI cases.
If I'm reading the question, like if they have a central line and they're acting sick
Yes.
and they're
There is a
generally we
central
would
line.
try.
Yeah.
I would try never to treat culture negative sepsis. Now I failed that, but I would try really hard if the cultures are sterile, even in the setting of having a central line, I would try to stop at 36 to 48 hours.
One more interesting question, Dr. Rohit asked that any role of oral antibiotics as primary therapy and for completion of therapy duration? So
that is an excellent question. The answer is we don't know. There is no pharmacokinetic. I mean, certainly for meningitis and bloodstream infections, no one's really ever been brave enough to try oral therapy in the US. For urinary tract infections, for pneumonia, for skin infections, we have lots of data that oral therapy is fine and maybe even superior in some cases for older kids. And you're starting to see people ask that question, but there's very little empirical data. We actually did, Pavel Prusakov, who wrote the Culture Negative Sepsis, we actually did a mock debate at the Pediatric Academic Society's meeting a year or two ago. And I had to take the side of no oral therapy, which is not what I believe. But basically, there's just not a lot of evidence. But I do think that if you've got a kid under your observation that you know is getting oral therapy and they've got a healthy gut, there's no reason to think that they would fail that therapy. We've just never been brave enough to do those studies. That being said, I used a lot of oral therapy when I was in Botswana for a period of time. We didn't have IV access. I treated a lot of pneumonia in young babies with oral therapy, and they seemed to do okay. And I don't know how many of them actually had pneumonia versus had viral infection versus prematurity, but but it's a great question. And I wish the more we can get away from our reliance on central, once we don't need central lines for nutrition anymore, the more we can get away from central lines and get those central lines out, the better. So I think it's an important question.
sorry, over to Dr. Prakash for the rest of the questions.
I think you have been very liberal in taking 30 minutes. I don't know whether we should go further. Manoj can advise me and the speaker as well.
We have covered almost all that topic.
That's right.
And this sepsis being a topic where the questions never stop, probably we
Job
can...
security.
Yeah, correct. So probably,
shall I end with two questions, one from my side and one from the question answer? My question is, what is the choice of antibiotics you give for neck? With perforation, without perforation? There is always a pressure to add metronidazole, although we are using big guns like tazocin and meropenem. I'm sure they cover anaerobes as well.
Yes, sir. You're exactly right. So the only randomized control trials for neck, we're looking at Ampingent versus Ampingent with an anaerobic agent. And Clinda is what's been studied, but like you said, metronidazole is probably the most commonly used. We use Zosyn monotherapy in my unit. And what they found is if you add anaerobic therapy, your rate of survivors go up and your rate of strictures go up. And so the theory has always been that those kids that would have died are now surviving with strictures. The sickest babies are now surviving with anaerobic. So I would always add anaerobic therapy with or without perforation. We use Zosyn monotherapy for everything. It covers enterococcus, gram negatives, it covers anaerobes. The only thing that Zosyn doesn't cover that flat metronidazole does, there's only one gap, and that's bacteroides. So if you had a peritoneal culture or a blood culture that grew bacteroides, then I would probably use Ampgent Flagyl. Meropenem will also cover bacteroides. I wouldn't routinely use meropenem, but if you're on meropenem anyway, that will cover bacteroides. That's the only thing Zosyn monotherapy doesn't cover. But we've had great success with Zosyn monotherapy. It's one drug. The nurses love it. They don't have to do as many line breaks. So I love Zosyn monotherapy, but we have to remember that it's not perfect for bacteroides. So that might be a role for Flagyl. But if you're on one or the other, you don't need both. So if you're on Flagyl, you don't need Zosyn or Clinda. If you're on Zosyn, you don't necessarily need Flagyl. So one anaerobic coverage should be fine.
If the baby preemie is on meropenem and vanco, metronidazole has no role. Am I clear?
No roll. Yep. Meropenem does everything Metro does.
Okay. I'll take one question about Dr. Rohit is telling, kindly comment on the role of endotracheal aspirate for suspected pneumonia, however, with an old tube, and how to take culture. Should we reintubate? Will they be representing colonization or infection?
Yeah,
What
this is
about
a good
an old
question. So,
new tube?
yeah.
Suppose you have put a reintubate, put a new tube.
Yeah, this is a great and complex question, and I don't have a perfect answer to it. We just have to remember that the upper airway, once you get above the get up in my camera, once you get above the mucociliary escalator, once you get to the trachea, you're no longer sterile. There's organisms up here. And so if you send an endotracheal tube aspirate, you are sampling a non-sterile site. And that's fine. We just have to remember that we're probably going to grow something, just like if we swab the skin. So you have to put it in context. If it's a brand new, new chest X-ray infiltrates and the endotracheal tube grows heavy growth of Pseudomonas and there's lots of white blood cells, fine, I'm convinced. If you send it and it grows 1+ Staph aureus and 1+ Haemophilus influenzae, that's what's supposed to be up there. So it's hard in that setting. And we don't, at least my center, we don't routinely get bronchoscopies or lower tract samples. So we're sort of stuck with the upper tract samples. But my tongue-in-cheek answer is diagnosing pneumonia just with an endotracheal tube aspirate is like diagnosing neck just with a rectal aspirate. You're going to grow something. You've got to put it in clinical context based on your X-ray findings and your clinical findings. But a gold standard for pneumonia would be another really valuable tool because we're always sort of stuck cobbling it together from this non-sterile culture and chest X-rays, which are often abnormal in our babies for a million different reasons. It's hard.
What about taking a culture soon after putting a new endotracheal tube within the first hour?
The advantage is you've cleaned, theoretically that wet plastic isn't colonized yet, but the tissue it's sitting in is still colonized. So I don't know that it makes a massive difference. And I do think we see a lot of colonization. And again, trends over time. So if it's 1+ Staph, 1+ Staph, 1+ Staph, and then the baby crumps and it's 3+ Enterobacter, okay, that's a change. But if it's always 3+ Enterobacter, that's just colonization.
I think one last question. I think really, what are the indications for CSF study in your unit, both for early onset and late onset?
So for early onset, we don't routinely do them. We would do a tap if the blood culture were positive, or if the baby had overt neurologic signs, so apnea, seizures, we would tap. For late onset sepsis, we are theoretically supposed to get them for all of our late onset sepsis workups before we start antibiotics. So if it's, kid had a cluster of B's and D's, we just got a blood and urine culture and we're watching, fine. But if they're going to start Oxygent, they're supposed to tap because gentamicin doesn't penetrate spinal fluid. It's hard to go back and tell retrospectively. So for all late onset sepsis treatment, we should have spinal fluid in hand. And I got another tongue-in-cheek answer for you. I always tell the residents there's only 2 reasons not to tap a baby. If they don't have a spine, right? So if they've got myelomeningocele or they've got sacral dysgenesis, if they don't have a spine, or if you don't have a spine.
That's an excellent answer. I think thank you so much for taking your precious time, overshooting the limits we are given. And it was a pleasure to listen to you, sharing your wealth of experience and knowledge. Over to Dr. Manoj.
So I again joined the chorus. Thank you, Professor CANTEY. It was a wonderful talk, well appreciated. And then, of course, this is a topic where now we need to update ourselves. So I'm sure that we would want you again. We would invite you again on another occasion when the more research has come out. Thank you so much for joining us today. I also thank
sorry, I was just gonna say thank you guys again so much for having me. Thank you for so many people coming on the call and all the wonderful questions. I really appreciate the engagement.
It's our honor, sir. And thank you both the moderators, Dr. Prakash Manikot and Dr. Subhash Chandra Shah, for moderating this session so very well. We had a lot of challenges managing all the questions. We managed it, and then we Before I close, I again want to thank all of you respected attendees who have been with us for the last 4 years, navigating through the various scenarios in neonatal medicine. And here we go. We take a break for a month. In April, we may not have one. And then in May, we continue again with our next lecture that will be on some new hemodynamic studies that has come up on a very common or rather very low cost intervention, kangaroo mother care. So until then, goodbye. Thank you so much. Let's continue to learn from the legends.
Thank you. Thank you. We'll keep in touch. Thank you so much. Yeah. Good day for Dr. Professor Joseph, and good night for people in India and the other places. Bye-bye.